So we will be starting with the examination of the heart. So before you do your cardiac examination, we always start with gathering of your data. So this is your history taking. Of course, your history taking is very important because it will provide you with an opportunity to achieve rapport with your patient. So a good history, as you all know, involves getting the facts, developing some leads, or digging deeper into the apparent facts. Like, for example, what causes the patient to seek medical help or seek medical consultation. And then with your history, if you have a very good history, you can now analyze and formulate an impression or a possible diagnosis of the case based on your history and physical examination. So some of the data, especially if the patient is very ill, you cannot get the information from the patient himself or herself. So you can get it from the members of the family or from significant others. So in cardiac examination, we always apply the general principles in taking medical history. So you start from the infancy down to the adulthood. So during infancy, you may ask if there is history of cyanosis and anoxic spells, or history of frequent upper respiratory tract infections, because upper respiratory tract infections are usually related to your rheumatic fever and rheumatic heart disease. And then if there is failure to thrive, because this one is usually associated when there is mga congenital heart diseases. And of course, if there is, example, a routine examination that the physician, the pediatrician, for example, has detected a murmur. So it's not normal for a child or for a neonate to have a murmur. So during childhood, you also ask if there is history of upper respiratory tract infection, discovery of a murmur, because diba, during childhood naman, especially that these patients are, the kids are already exposed, pwede silang, they develop some infectious diseases like upper respiratory tract infections, and that's the start when the patient would develop rheumatic fever and rheumatic disease. History of streptococcal infections. So your streptococcal infections, your throat and skin infection are usually associated with your rheumatic fever and rheumatic heart disease. The skin infections, streptococcal skin infection, are usually common, or the common cause of your glomerulonephritis. It's usually the streptococcal throat infection that is associated with your rheumatic fever and rheumatic heart disease. Although there are some also who had streptococcal skin infection that develop rheumatic heart disease and rheumatic heart disease. But what I'm saying is that throat streptococcal infection is the common cause for your rheumatic fever and rheumatic heart disease. And then you ask if there are any unusual diseases during childhood. So adulthood, you ask for history of tuberculosis, Cox infection, history of prolonged fever. Why do you have to ask for TB? Because the patient has developed mga right-sided failure, manifestations of right-sided failure, and this is usually associated with your cor pulmonale, and the common cause of your cor pulmonale is a chronic TB or history of TB. Prolonged fever is also, this could be an indication that there is an infective endocarditis. whether it's acute or subacute. But kasi pag prolonged, it's usually subacute endocarditis. And then history of chest injuries, venereal diseases. So why do you have to ask for mga STDs or venereal diseases? Because this is actually associated with your dissecting aneurysm or dissection, aortic dissection. Then for female, you ask also the number of pregnancies and complications during pregnancy, because diba, pregnant women could develop your eclampsia, pre-eclampsia, eclampsia. So your eclampsia is associated with a very high blood pressure, and these patients may develop eventually chronic hypertension. Then why do we ask also for the number of pregnancies? Because the pregnant women are usually may develop postpartum or peripartum cardiomyopathies, and they are common usually in mga in primary. So the family history is also very important. You may ask for history of diabetes in the family, hypertension, your coronary artery disease, sudden cardiac death, congenital heart diseases, and cardiovascular diseases in the family. So for your personal and social history, it's the same with your when you are getting the general data ng patient, the civil status, the religion, work situation, so socioeconomic status, because all this can also can either trigger heart failure, for example, mga stress sila sa work. There are also, for example, religion where they are not allowed to eat any meat or any meat product, and they may develop anemia. Severe anemia can lead to high output failure. So these are all important personal history in your patient that may give you a clue as to what is the possible cardiac condition the patient is having. Alcohol and tobacco use. So alcohol, it can be associated with your mga cardiomyopathies, your physical activity. So mga obese patients, they are more prone to develop especially very obese or morbidly obese patients, they are prone to develop obstructive sleep apnea, and obstructive sleep apnea are associated with your cardiac arrhythmias. So these are all important things that you have to consider in your history. So next are the symptoms. You need to clarify and ask for specific symptom that may lead you or give you a clue as to what the patient is having. So one of the important symptom of heart disease is pain, or your cardiac pain, or it is also called as your angina pectoris. Your angina pectoris is due to myocardial ischemia caused by coronary atherosclerosis. So this may occur in severe aortic stenosis, also with intact coronary. So patients who have severe aortic stenosis may also develop severe chest pain. So one of your differential diagnoses is we have a patient who have angina pectoris is also severe aortic stenosis, because it may also present with angina pectoris. So the mechanism here is actually a myocardial oxygen demand which is in excess of the supply. Meaning to say, kasi if you have aortic stenosis, the heart compensates, so na it will hypertrophy. So when your myocardium is hypertrophied, the blood supply is actually it will not increase the blood supply, the coronaries, di ba? So because of the thickened myocardium, there is a relative low supply to the myocardium because of the thickened myocardium. So there is an imbalance between oxygen demand and supply. Your angina could also be paroxysmal. This could be noted during emotional upset or emotional stress. Some patients who describe angina pectoris as squeezing or crushing in the anterior or substernal chest. It may also radiate to the left shoulder and down to the inner aspect of the arm, the elbow, wrist, and fingers. So it may also radiate to the jaw, the root of the neck, the back, and epigastrium. Some may describe it only as localized chest pain. So it's located only in one particular area of the chest. So it may also be described as heaviness, a mild ache, or even a stomach upset. So if you have a patient presented with epigastric pain, so one of your consideration is myocardial ischemia or myocardial infarction, especially if you are dealing with an inferior wall myocardial infarction, because it is proximate with your with the stomach. Kaya they may develop also epigastric pain. So usually the pain subsides after rest or after intake of nitroglycerine. So your physical and emotional factors may trigger, or sometimes it may also relieve. For example, if you stop your physical activity, there is relief of chest pain. But when you exert effort, or when the patient exerts effort, there is trigger of the chest pain or aggravation of the chest pain. So if the patient is experiencing myocardial infarction, the chest pain here is more severe. So it's more severe and it lasts longer, and it is usually not relieved by rest and nitroglycerine. In pre-infarction syndrome, this is also called as intermediate coronary syndrome. Usually the patient will describe the pain as progressive. So the angina is progressive. So before, for example, they only have chest pain occurring only at rest occurring only during activity. But now it is becoming progressive, noted even at rest. So this is called as your pre-infarction or your intermediate coronary syndrome. It's also called as your unstable angina. So in this condition, the angina is more severe. So it may become more severe than the previous one, and it is becoming more frequent, occurring even at rest or recumbency that lasts for up to half an hour with or without relief of nitroglycerine. So what are the conditions that will also present with chest pain? And these are the conditions that you have to consider as differential diagnosis when you are presented with chest pain. So one is dissecting aneurysm of the aorta. So in the dissecting aneurysm of the aorta, the chest pain is described as tearing. So it's a tearing anterior chest or back pain, severe at the onset. So pag start pa lang, severe. It is prolonged and radiate into the neck or down to the abdomen. And you will have an obliteration or a diminished brachiocephalic and lower extremity pulses. In pulmonary embolism, this is another condition also that may present with chest pain. So, however, in small pulmonary embolism, it may be painless. But the common manifestation for pulmonary embolism is dyspnea, where it has pleuritic chest pain that is made worse by deep breathing and coughing. Sometimes your myocardial infarction may also present with dyspnea. So it's called as angina equivalent. But when you do your electrocardiogram, for example, or you get the cardiac enzyme, there's elevation of your cardiac enzymes. And actually, the patient is experiencing myocardial infarction. So the presentation is only dyspnea. So your MI may have similar presentation with your pulmonary embolism, like presenting only with dyspnea. So acute pericarditis is another condition that may also present with precordial pain. So the pain here is sharp or diffuse, aggravated by turning, coughing, or even swallowing. So it's maybe relieved by sitting up and radiate to the shoulders and neck, and occasionally to the epigastrium. However, in acute pericarditis, it's usually preceded by fever. Then another is musculoskeletal pain. So if you have cervical disc or arthritic pain, it may also present with pain, but it's more of a radicular pain coming from your dorsal root. It may be felt in the shoulders and upper chest and back, and the pain is described as lightning-like, radiating from back to front. So another condition that may present with chest pain is your anterior costochondral pain or your Chit syndrome. So in Chit syndrome, usually the pain is localized to one or two costal cartilages. So when you palpate the cartilage, so you can localize where the pain is. So it could be localized to one or two of your cartilages. And it may also diffuse when many ribs are involved. So when you examine, there is swelling, redness, and tenderness on pressure of the involved area. So another that may also present with chest pain is anxiety, and this is common. So this is the most common cause of a sharp anterior chest pain, especially among women. So it may be inflammatory, but may move from place to place, and it's not related to exertion. So usually the pain is aggravated by emotional upset or triggered by emotional upset. So it's located by the patient with a finger rather than with a palm or fist. So associated symptoms when there is anxiety include breathlessness, tachypnea, chest tightening of hyperventilation. Di ba kasi nag-hyperventilate sila if they are anxious, panic attack. Because of hyperventilation syndrome, they may experience dizziness, numbness, and finger straining, but which is not actually a carpopedal spasm. So this is one of the condition that you have to consider when you have patient with chest pain. So that's why it's one of the differential diagnosis, because these patients also may develop numbness, and numbness of the left upper extremity is also seen in patients who have myocardial infarction. So other differential diagnoses that you have to exclude, especially if you are dealing with a cardiac problem, are your peptic esophagitis. So it may present with heartburn, hiatus hernia, your gallbladder disease. However, in gallbladder disease, it is usually triggered by intake of fatty food, stomach and duodenal disease, as I mentioned earlier. It's usually due to mga heartburns. Here, the pain may extend to the lower chest or upper back. And some may be relieved by nitroglycerine, like your esophagitis. So it could be relieved by nitroglycerine. So another symptom that is seen in patients with cardiac problem is dyspnea. So usually the dyspnea here is described as distressing sense of breathlessness or difficulty in breathing or a labored breathing. So your dyspnea could be cardiac or pulmonary in origin, or even extracardiac in origin. So you can have Stokes respiration, which is commonly seen in patients with CNS disorder. And this is a periodic breathing. So you have episodes of apnea and hyperventilation when you have Stokes respiration. And then Cosmos breathing is also another cause of your dyspnea. And this is commonly seen in patients with diabetic ketoacidosis. So when you have dyspnea that is due to heart disease, it is usually due to a pulmonary venous congestion or hypoxemia. So in pulmonary venous congestion, there is usually LV failure or mitral stenosis as the cause of your pulmonary congestion, or the presence of a left atrial myxoma. Hypoxemia also can lead to dyspnea, and this is usually due to a left to right shunting with aggravation during exertion and severe anemia. So wheezing can also be observed in patients with cardiac problem, and this is called as your cardiac asthma. So the wheezing here is due to pulmonary congestion. So dyspnea on exertion or effort dyspnea are also one of the common manifestation that is seen in a patient with heart disease. And this is actually the earliest evidence of a functional limitation or incipient cardiac compensation. So orthopnea is another manifestation in a patient with heart disease, and it is described as dyspnea on recumbency. So here the patient will sit or prop himself up with pillows. So the mechanism here is because of the shift of your blood to the pulmonary circuit when the patient would lie down. Paroxysmal nocturnal dyspnea is a dyspnea that occurs 1 to 2 hours after retiring normally to bed at night. This is due to the gradual transfer of blood volume during recumbency to the pulmonary circuit, meaning when the patient is sleeping, probably he or she is propped up in a pillow, mga 2 pillow for example, but then mga after 2 to 3 hours, probably nahulog siya from that elevations of the the pillow, and the patient would experience the gradual transfer of blood to the pulmonary circuit kasi naka-flat na siya. And the patient would be awakened at night, gasping for breath. Acute pulmonary edema is severe condition of pulmonary congestion. So kumbaga, the lung is already flooded with fluid. And this is due to severe left ventricular decompensation or when you have a mitral block. So pulmonary venous and capillary pressure here already exceeds the osmotic pressure of the serum protein, resulting to transudation of fluid into the alveoli. So that you have already flooding of the lung. So the patient here will complain of extreme breathlessness accompanied by fear. So he or she may be cyanotic or pale. So cyanotic because hypoxemic na siya. or pale because of a decrease in or a very low cardiac output. Usually patients will have use of accessory muscles of respiration. So they are hypotensive with very fast heart rate and respiratory rate. And then there is wheezing and rales that is noted bilateral with profuse wetting. And there is pink frothy secretions coming out from the nose and mouth. So this condition may also develop in an otherwise normal heart. And this is seen in patients who develop head injuries, inhalation of noxious substances, or iatrogenic fluid overload. So this is called as non-cardiogenic pulmonary edema. So Stokes breathing, as I mentioned earlier, is a periodic breathing frequently seen in elderly with heart disease. So it's not only patients with CNS problem, but you can also see Stokes respiration in patients with heart disease. So the breathing here is described as waxing and waning of respiration with in-between periods of apnea. So when a patient with heart failure develops Stokes respiration, this is an indication of an unfavorable prognosis. So respiratory dyspnea is also called as labored breathing, and this is due to lung disease. Kasi kanina, di ba, cardiac asthma, you can have cardiac asthma. You can also have respiratory dyspnea. And usually this is due to mga lung diseases like in restrictive disease, obstructive pulmonary disease, or when there is diffusion-perfusion abnormality, when you have alveolo-capillary block or lymphocytic carcinomatosis. So here, it's not, it's effort related, but it is not influenced by position and frequently accompanied by cough. So edema occurs when the capillary pressure exceeds osmotic pressure and the lymphatic system cannot drain the transuded blood fast enough. So when the serum osmotic pressure is considerably lowered from reduction of serum albumin, your edema may also occur. So obstruction also to venous or lymphatic flow, like in cases of thrombophlebitis or when you have varicosities, you can also have edema, but usually the edema here is unilateral. So peripheral edema and pulmonary edema are late manifestations of heart failure. So it occurs in the afternoon, it spares the face, preceded by dyspnea, and it is attributable to a right-sided failure. So when you have left-sided failure, there is salt and water retention via your aldosterone as a result of a reduced renal flow from a diminished cardiac output. So cardiac edema is usually dependent. So it's seen in the lower extremities or in the pre-sacral area in bedridden patients. So detection of non-cardiac edema is very important. Although you also have to rule out cardiac cause. So what are the other causes of your edema? As I mentioned earlier, you can have edema due to liver problem or edema from a renal disease. So another important symptom is your fatigue. So fatigue is not cardio-specific because it can also be seen in other conditions. If it is due to heart disease, this is actually a result of inadequate cardiac output with diminished tissue perfusion, including the central nervous system. So it goes hand in hand with dyspnea. So the most common non-cardiac cause is anemia, thyrotoxicosis, your chronic debilitating illness. So, pwede silang mag-develop ng fatigue, malnutrition, Addison's disease, and hypothyroidism, and plain laziness. So cyanosis is a bluish discoloration of the skin. So it becomes visible when the area are at least 5 grams when there are at least 5 grams of unsaturated hemoglobin. So your arterial desaturation may exist without visible cyanosis if the hemoglobin is less than 5 grams. So anemia, the arterial desaturation here may not become evident when you have anemia. So cyanosis is a result of arterial unsaturation in cases of congenital heart disease, your tetralogy of Fallot, your intraatrial septal defect, the interventricular septal defect, and PDA. It may also be due to pulmonary causes. So the cyanosis may also be due to pulmonary causes. So if you have central cyanosis, this is actually associated with digital clubbing, while peripheral cyanosis, this is arterial saturation. There is usually arterial vasoconstriction that causes the peripheral cyanosis, like when you are exposed to cold. So here the saturation is normal, but as I've said, because of vasoconstriction, you have cyanosis. There is also increased tissue extraction of oxygen, so that you have widening of the arteriovenous oxygen difference when you have venous capillary blood that is more saturated. And this is seen in patients with low output states. So your cyanosis is best detected in the fingertips, the tip of the nose, the earlobes, and the underside of the tongue. So it may also be episodic or may be worsened during anoxic spell in patients with tetralogy of Fallot. So palpitation is also another symptom that is seen in patients with heart disease. So it is described as a conscious awareness of the heart beating. So normally, we do not notice the heartbeat, diba? So it is normally unnoticed and would only reach the level of awareness if the force of contraction is increased. So pathologically, in a more forceful contraction, like that's seen in aortic regurgitation, when there is a change in the cardiac rate, either an increase in the rate, so you have tachycardia, or a decrease in the rate, or you have bradycardia, or a sudden rhythm change, meaning there are mga ectopic rhythms or paroxysms of mga ectopic beats. So patients may describe palpitation as a skipped heart, jumping or running over inside, raising, or sudden stopping or sudden choking feeling. So when the patient would complain of palpitation, ECG is mandatory. So you will see what is the rhythm abnormality. So hemoptysis is described as coughing out of blood. It could also be due to a pulmonary problem, like when you have cavitary TB, pneumonia, bronchiectasis, bronchogenic CA, or presence of foreign body in the bronchus, or a cardiac disease when there is already pulmonary edema, mitral stenosis, and pulmonary infarction. In pulmonary edema, the hemoptysis here is due to the increase in capillary pressure, so that because of the increase in capillary pressure, some of the small capillaries rupture, so that the secretions are described as pink and frothy or even grossly bloody. So mitral stenosis also may present with hemoptysis. So the hemoptysis here is actually due to rupture of pulmonary veins or pulmonary venous collaterals from high venous pressure that is precipitated by excitement or exertion. In pulmonary infarction, in pulmonary infarction, this is a result from pulmonary embolism or from cytothrombosis in a hypertensive congested lung. So frequently it is associated with tachycardia, tachypnea, and pleuritic pain and cough. Syncope is a sudden but transient loss of consciousness, and it is also seen in patients with cardiac problem. So the syncope here developed because of an inadequate cerebral blood flow. This may be due to cardiac, neurogenic, vasomotor, and cerebral causes. When it is cardiac, it is because of the sudden change in your rhythm, or it could be from an obstructive lesions like in patients who have severe pulmonic stenosis or aortic stenosis, and it is usually described in AS as effort syncope with angina. It also can be seen in patients with pulmonary embolism and left atrial myxoma. So cyanotic lesions also may have or may develop syncope. Usually it's an anoxic spell that is aggravated by exertion. And this is commonly seen in patients with tetralogy of Fallot. So syncope that is due to autonomic instability, that is due to autonomic instability could be related to your carotid sinus syncope. So very, very sensitive carotid sinus. It could also be due to cough syncope or from a micturition syncope and vasovagal syncope. So these are some of your differential diagnoses that you have to consider when your patient presents with syncope. So I guess this is my last slide. So thank you for listening. Do you have question? Wala na kang pakiana siguro kaya nag-i-study ka mo ano. Sige, pag-attendance na.
Done na po, Doc.
Done na. Okay, sige. Good luck. Good luck to your exam this afternoon.
Thank you, Doc.